rheumatoid arthritis, osteoarthritis, gouty arthritis, pseudogout, psoriatic arthritis, and ankylosing spondylitis, right? So so that was sort of a homework to get you all prepared for this tutorial, right? Right. So we will start with this short case history, right? Now there is a 22-year-old male patient. So at the moment, I hope that you all have background knowledge. You have studied about spondyloarthritis and rheumatoid arthritis as well, right? And this is the short case history. A 22-year-old male patient presented with intermittent low back pain, right more than left, with radiation to the lateral hips, but no radiation below the knee, right? This pain was started without any precipitating event. Things got worse over the past 2 months, and the severity fluctuates from mild to quite severe pain. And basically, the symptoms are worse in the morning or following prolonged rest. And there is no history of paresthesia, weakness, or radicular features. And then he denies any bowel or bladder dysfunction, and there is no history of saddle anesthesia, right? So this is happening in a 22-year-old male patient, right? Yeah. Now, after going through the history, can you all list 3 possible causes for above presentation?
Ankylosing spondylitis due to the age and the clinical feature of low back pain.
Right, okay, so now we will list 3 possible causes, right? So ankylosing spondylitis, agree. Anything else? Any other condition which can affect in a similar manner? So now, is this rheumatoid arthritis or spondyloarthritis?
Spondyloarthritis.
Spondyloarthritis.
Spondyloarthritis rather than rheumatoid arthritis, isn't it? Rheumatoid arthritis, you get involvement of the peripheral joints, small joints, right? And mainly symmetrical, mainly in a symmetrical manner. But here, mainly the back is affected, mainly the axial skeleton is affected, right? So this is more favor of spondyloarthritis rather than rheumatoid arthritis, right? So one differential diagnosis coming under spondyloarthritis is ankylosing spondylitis. What else? So what are the other different entities coming under spondyloarthritis?
Enteropathic arthritis.
So it can be enteropathic arthritis, very good, right? So it can happen
Psoriatic arthritis.
after diarrhea, right? And it can be due to psoriatic arthritis, right? Anything else?
Reactive arthritis.
So it can be due to reactive arthritis as well, right? It can be reactive arthritis, spondyloarthritis, right? Or it may be due to ankylosing spondylitis as well, right? So now, apart from the joint involvement, what are the other features that supported the diagnosis of kind of a arthritis rather than rheumatoid arthritis in this patient's history?
Young age of onset.
Right. So this is again a young patient, isn't it? The patient age is 22 years, right? So again, 22-year-old. So what are the other things which should support the diagnosis of ankylosing of spondyloarthritis in this patient?
Axial skeletal involvement.
Right, axial skeletal involvement, age, anything else?
Male patient.
And then now this is a sort of a male patient. So this has happened in a 22-year-old young adult, right? And a male patient, right? Coming with basically involved in the axial joints, right? And going on for nearly 2 months. So is it a, can this be osteoarthritis? So is this history suggestive of osteoarthritis or any kind of inflammatory arthritis?
Inflammatory arthritis.
So this looks like an inflammatory arthritis, isn't it? Rather than osteoarthritis. So why do you say that?
Symptoms worse in morning and following prolonged rest.
Symptoms are basically worse in the morning and after a prolonged rest, right? But in osteoarthritis, the things will get worse with movements and mobility and all that, right? Walking and weight bearing and all uh, will aggravate the symptoms of osteoarthritis. But they also can have little bit of worsening symptoms in the morning as well, right? But this is classically of inflammatory kind of arthritis, right? Okay, right. So now we have listed 3 causes, right? Ankylosing spondylitis, psoriatic arthritis, and possibly we will take third one as reactive arthritis, right? So what are the other clinical features you would elicit to differentiate 3 causes listed? So what are the other, if you are now, when you think about ankylosing spondylitis, what are the other clinical features you would try to elicit in the history and on examination that would support the diagnosis of ankylosing spondylitis? So we have to take one by one. Ankylosing spondylitis first, then psoriatic arthritis, and then reactive arthritis.
Ankylosing spondylitis patients has alternating buttock pain and with lumbar lordosis and non-articular features like
Yeah,
uveitis.
just hold on. I'm receiving a call and right. So can you repeat it again?
In ankylosing spondylitis, patient experience alternating buttock pain and there is lumbar lordosis and non-articular features like uveitis and there's mainly axial joint involvement and
Right. So you need to be more specific. Now when you take this patient again in this patient's history, the history itself says the patient is having alternating kind of buttock pain, right? So you have to list the other features, other clinical features that would support ankylosing spondylitis.
Apical fibrosis on respiratory examination.
Okay. Right, very good. So if the patient is having features of apical fibrosis, right, that is another feature of ankylosing spondylitis. Yes, right. Anything else?
Kyphosis, decreased cervical movement and spinal movement, and
Okay.
decreased chest expansion.
Right, decreased chest expansion. Agree. Right. So with the spinal movements and all that, so all these are late features, but again with the spinal movements and all that, can you be more specific? About the neck and all that? So what would happen to the neck in advanced ankylosing spondylitis?
A bamboo spine, the fusion of the vertebrae.
Extension.
Okay,
Question
so
mark.
the bamboo spine and all that are radiological features. Clinically, what would, especially in advanced ankylosing spondylitis patient, what would happen to the neck?
Neck
Pain
hyperextension.
and the reduce.
Next, so what is the deformity they will get? Flexion or extension?
Hyperextension.
Question mark posture.
Like question mark kind of thing. So then if we divide, there is a flexion or extension, neck.
Extension.
Okay, we will, I have a slide on that, so we will come back to that later on, right? Anything else? Something to do with the cardiovascular system? So that is again a sort of a late feature.
Aortic
Will not be-
regurgitation.
So the patient can develop aortitis, and the patient can have aortic regurgitation as well, right? Anything else?
Achilles tendinitis.
Plantar
Okay.
fasciitis.
Right, so they can have Achilles tendinitis and then plantar fasciitis as well. So why do they develop? So what is Achilles tendinitis?
Enthesitis.
So that is a part of a enthesitis. So what is enthesitis? What is enthesitis?
Inflammation of the attachment of
Inflammation and
tendons and
local
ligaments to the
erosion
bone.
of
Right, exactly, right, very good. So then there is something to do with the inflammation at and around insertion of a tendon or a muscle or into a sort of a bone. So that is a classical feature of spondylo-arthritis, right? Rather than rheumatoid arthritis. Okay, right. So again with patients with ankylosing spondylitis can also have features of enthesitis, right? Agree. Anything else?
Anterior uveitis.
Okay, again anterior uveitis, again this is sort of an extraarticular manifestations of all spondyloarthritis, right? So that can happen in reactive arthritis as well. So that can happen in patients with psoriatic arthritis as well. Right. So what would the features? So if you think now, so your second differential diagnosis is psoriatic arthritis, right? So if you are thinking about psoriatic arthritis, what are the clinical features you are going to elicit?
Specific nail changes for psoriasis.
So what are the specific nail changes?
Nail pitting.
Right, nail pitting.
Onycholysis and transverse ridges.
Right, transverse ridging, nail pitting, transverse ridging, and onycholysis. So you have to, so if you want to get full marks when it comes to exam setup, right? So you have to write the answer like that, right? Psoriatic arthritis. So if you are about describing about nail changes, so I'm going to look for nail pitting, nail ridging, and onycholysis. You have to be really specific, right? Anything else?
Psoriatic rash.
So again, right, psoriatic rash, okay, plaques, psoriatic plaques, and all that. Anything else? Apart from the axial skeleton, what are the other joints which can get involved with psoriatic
Peripheral
arthritis?
joint involvement. Peripheral joint involvement, small joints, and arthritis mutilum.
So what are the peripheral? So again, you have to be specific. to get full mark, right?
Distal
You just have to
interphalangeal
look
joint.
So you have to look for involvement of the distal interphalangeal joints, right? Distal interphalangeal joints. Anything else? So again,
Dactylitis
someone mentioned about arthritis mutilans, right? Okay, agree. Dactylitis again, like anterior uveitis. Dactylitis can happen in patients with all kind of spondylo-arthritis. Okay, that can happen when after reactive arthritis as well. Right. So psoriatic now, where are you going to look for psoriatic plaques?
Extensor surface of the hand.
Right. Okay. Extensor surfaces and all that. Anywhere else?
The hair starting line.
So again, right, you have to lift the sort of the hair and you have to look for plaques in and around the hairline, right? Anywhere, anything else? Anywhere else?
Previous scars. That's a Kobner's phenomenon or something.
I didn't hear you clearly.
Scars or trauma sites.
I can't. I didn't. It's not clear. Any other places apart from the hairline and all that?
Umbilicus.
Umbilicus.
And scar marks. Trauma sites.
Trauma sites. Okay.
So is there anything called Kobner's phenomenon or something?
So we are going to discuss about something here, Kobner phenomenon, and so I am asking about the places where the psoriatic plaques can be hidden, right? One is umbilicus.
Behind the ear.
Behind the ear, right? And posterior to the ear and over along the behind the ear, right? Okay, right. So then, number one we covered ankylosing spondylitis. Then the number two is psoriatic arthritis. So you look for nail changes, nail ridging, nail pitting, and onycholysis, right? And then you look for peripheral joint involvement, mainly distal interphalangeal joint involvement. And then you have to look for psoriatic plaques, especially hidden ones within the umbilicus and over the hairline and then behind the ear as well, right? Sometimes it can be hidden over the buttock area as well, right? So what is the third one? Third differential diagnosis? Reactive arthritis, right? So in the history and on examination, what are the clinical features you are going to elicit?
Preceding infection few weeks ago, like dysentery and diarrhea,
Right.
and urethritis.
So preceding history of diarrhea or anything, something like urethritis, right? Even any other sort of a viral infection can precipitate reactive arthritis. Okay, any history, recent past history of infection, diarrhea, or history of urethritis. Anything else?
Arthritis mostly in the lower extremities.
Okay, very good. So in addition to the axial skeletal involvement, these individuals can, the lower limb joints can get involved in patients with reactive arthritis, right? Even the upper limbs can be affected. Right. Anything else?
Associated enthesitis, fasciitis,
Okay. Right, associated enthesitis. So that can happen in other spondyloarthritis as well, but it will be more common following reactive arthritis, right? Especially Achilles tendinitis and plantar fasciitis. Right? The patients will complain heel pain and all that, right? Especially early in the morning. Anything else? Any other dermatological?
Sarcinated
Class 1
balanitis.
sole and palm.
So what do you call that?
Keratoderma planoregica.
Right, Keratoderma planoregica, right? So anything else?
Sarcinate balanitis.
Right, the patient can have sarcinate balanitis as well, right? Sarcinate balanitis as well, right? So when you are asked to list clinical features that would support to differentiate these conditions and all that, you have to be really specific, right? Someone can say now again. So when you are start marking papers and all that, right? Somebody might come and write something like skin rashes and all that. So the other person can go and describe the psoriatic plaques. So the third person might come and tell specifically, I would look for hidden ones in places such as behind the ear and umbilicus and all that, right? The person who has given the complete answer should get more marks, right? Suppose the patient about psoriatic arthritis and all that, some person might tell that apart from the axial involvement, patient can have involvement of the small joints of the hands. The other person will come and say distal interphalangeal joint involvement, right? The third person might come and say distal interphalangeal joint involvement with nail changes. The fourth person will tell distal interphalangeal joint involvement with nail rigid, nail pitting, and onycholysis. The full marks has to be given to the fourth person, isn't it? But the knowledge-wise, it may be same in all four individuals, right? But again, when you examine a patient, again, that is how you should examine, right? You can just, one person can just look for joint involvement. Other person can specifically look for involvement of the distal interphalangeal joints, right? Other person can just look at the nail changes. So other persons would specifically look for nail pitting, rigid, and onycholysis and will document that. So fourth person should get full marks, right? Do you all agree? Right. Okay. So now we initially had 3 differential diagnoses, and then we look for clinical features supporting each of the condition, right? So now can you all list investigations you would request in this patient? So what are now this patient as present? So what are the investigations you want to do? Can you all hear me? Hello?
Yes, sir, we can hear you.
And then there is a patient coming in now, backache. So what do you want to do? So do you want any rheumatological investigations?
Yes, sir. Full blood count.
Okay, full blood count. Very good. Anything else?
Yes, sir.
ESR, right? ESR 98.
CRP.
CRP again raised 52.
Rheumatoid factor.
Rheumatoid factor again, right? You can ask. And rheumatoid factor is negative. Better to ask rheumatoid factor theta if you are asking, right? What?
ANA.
ANA, right? You can ask again, right? ANA also negative.
Thinner iliac cartilage.
So again about sacroiliac joint. So they can develop erosions, isn't it? They can develop erosions of the sacroiliac joint. And in addition, they can subsequently develop sclerosis and narrowing of the joint space as well. Initially they will develop erosions of the sacroiliac joint, right? So any other investigations you want to do? Any other investigation you want to do?
We can do an MRI to check sacroiliitis before it is seen on X-rays.
Okay, so you can do the MRI scan, agree, right? So it will be very difficult to get a MRI done in our setup, but still it is more sensitive than the X-rays, right? To detect erosions and joint involvement in ankylosing spondylitis, right? Any other investigation you want to do?
HLA-B
Right, very
27.
good, very good. Right, so you can go ahead and do HLA-B 27 gene analysis, right? HLA-B 27, that is again, if it is positive, it should support the diagnosis of ankylosing spondylitis and any kind of spondylo-arthritis. But more in it will be more positive more in ankylosing spondylitis in about 70% of patients, right? Right. Okay. So you do X-ray, and specifically you are going to look at the sacroiliac joint, and then you look at the lumbosacral spine and the cervical spine, right? So you would request for HLA-B27, ESR, CRP, full blood count, and if you want, you can ask for about and CCP antibodies as well. But again, highly unlikely this would be due to rheumatoid arthritis with the given history. Right. Okay. Right. Now, can you name a bedside test that would support ankylosing spondylitis?
Positive Schober's test and wall to occiput distance.
Right. So number one, so you can go for Schober's test. So what is this test? What do you do in that test? So how am I going to do it?
Mark the midpoint of dimple of Venus, and then mark 10 cm upward direction and ask patient to touch the floor without flexing the knee as much as possible.
Right. So this is basically how they do it, right? You get the patient to stand upright, and then you make 2 marks on patient's back. One at the level of the sacral dimples. So that is at the 5th lumbar spinous process, right? And then another mark 10 centimeters above that. right? And then you ask the patient to bend forward as much as possible. And then you again measure the distance between two marks, right? So normally this has to be more than 15 centimeters. So initially the 10 centimeters should be increased by 5 centimeters in a normal individual, right? So this is not going to happen in patients with spondyloarthropathy, especially in ankylosing spondylitis, right? Got it? Hari neda? Clear neda? Are you all clear?
Yes, sir.
Right. So then now initially also you all mentioned about cardiovascular complications, right? So one cardiovascular, the major cardiovascular complication they could develop is aortitis and aortic regurgitation, right? So the respiratory wise, they can develop sort of a restrictive kind of lung disease due to reduced movements of the chest wall and all that, right? And in addition, they can develop right apical fibrosis. Okay, so this is they basically X-ray showing sacroiliac joints, right? So if you very carefully look, there may be some erosions over here, right? So again, when you're given an X-ray, when you do an X-ray of a patient who is presenting with lower back pain and all that, you have to very carefully look at this sacroiliac joint. So it has to be something like here in a normal individual, right? So here there may be some sort of sclerosis, right? Again, here also sclerosis, and the margins may not be very clear in this X-ray. Right? So when you start your clinical appointments, whenever you see a patient, say lumbosacral spine and all that X-rays, you should very carefully look at the sacroiliac joint, right? So then you will see 1001 normal sacroiliac joints before you suddenly detect a abnormal erosion or a sclerosis of sacroiliac joint, right? So now you have done the X-ray. Now ESR is 94, CRP high, rheumatoid factor and all that negative. So you have done the sacroiliac joint X-rays. There is a little bit of sclerosis and marginal erosions. So how are you going to manage this patient?
I would refer the patient for physiotherapy department for spinal exercises to prevent fixed spinal deformities.
Okay, very good.
And I would, as initial therapy, I would start the patient on NSAID.
Okay, mainly pain relief, right? Okay, pain
Okay.
relief. So you can start with paracetamol and then non-steroidal anti-inflammatory medications, right? Anything else?
If the patient is not responding to painkillers, then I would consider biologicals, TNF alpha.
Okay, so again, what is the problem with TNF alpha, all these biological agents? Are they freely available?
Expensive.
Huh? Very expensive, right? So now again, still, so we have to consider that, right? Still patient is in pain. What are the other medications which you can start?
Steroid
Self-sustaining,
injections.
Right.
methotrexate,
Okay. You can try steroids, right? So what is the kind of spondyloarthropathy where you have to avoid steroids? Not in any kind.
Psoriatic
Yes.
arthritis.
Psoriatic.
If the patient is having psoriatic arthritis, you are not going to start steroids. Why?
that will worsen the skin
The
lesions.
Very good. So that steroids can worsen skin manifestations of psoriatic in psoriasis, right? Okay. Steroids and pain relief, exercise, and all that. And then you can try methotrexate and sulfasalazine as well, right? Methotrexate and sulfasalazine as well. But if the facilities are available, I think we should start alpha as soon as possible if there is, especially as this patient is having sacroiliac joint erosions and little bit of sclerosis as well, right? So why do you have to manage them very aggressively with physiotherapy, exercises, and all that, and all these biological agents and all?
It could lead to irreversible kyphosis and wasting of the paraspinal muscles.
Right. Okay. Very good. So that this can lead to sort of irreversible damage can happen. So then, especially the patient will develop kyphosis and very stiff back, right, with all these features of bamboo spine and all that, right? And so then, all the flexion deformities and all that of the neck and all that. So then it will be too late. So you have to prevent that happening. Like in rheumatoid arthritis, you want to prevent them getting various deformities and all that due to erosions and all that, right? Like same thing would apply for ankylosing spondylitis as well, right? You are going to prevent the irreversible damage the patient could develop by commencing physiotherapy and other analgesics and other biological agents, right? Okay. Right. So what has happened to this patient's spine? Have we managed this patient properly?
No,
No. So what has happened to his spine?
the intervertebral spaces have been breached up. The bamboo spine difficulty.
Okay. So what are the prominent features here?
Vertebral syndesmophytes.
So there are syndesmophytes, isn't it? Right? Syndesmophytes again. This is due to new bone formation, right? New bone formation. Syndesmophytes. Anything else?
Shiny areas,
Methanol.
bilateral involvement.
Calcification of
syndesmophytes in both sides.
intervertebral ligaments.
Right. So there is calcification of the intervertebral ligament, right? And then what has happened to the shape of these vertebrae? So are they triangular or something else? So there is almost squaring of vertebrae, isn't it? Right. So this is a sort of a X-ray findings of advanced ankylosing spondylitis. So we have to identify them, we have to confirm the diagnosis, and we have to initiate therapy to prevent them developing or going into this late stages. Right? Right. So what is this? This is in a normal individual, right? This is in a normal individual. So this is in a patient with
Ankylosing spondylitis.
Right. Okay. So then look at this lumbar curvature. It has gone. So it's almost a straight spine here. Right. So in addition to that, so the cervical vertebrae will get fused, and then there will be chin to chest head position due to fixed cervical flexion. Right. So actually what you can do is, when you can ask the patient to sort of lie on a sort of a wall, and then actually you can measure the distance between the occipital region and the distance between the occipital region and the wall, right? So it is almost in a sort of a straight line in a normal individual, right? But definitely in a patient with ankylosing spondylitis, the distance will be increased, right? Due to the chin to chest head position, due to fixed flexion of the cervical spine. හරිනේ අර කලින් ප්‍රශ්නට උත්තරේ හම්බුණානේ දැන්නේ. So this is a patient with advanced ankylosing spondylitis. Okay. Right. So again, later on, this patient has presented with painful red left eye with blurring of vision. So what is the diagnosis?
Anterior uveitis.
So acute anterior uveitis, right? Acute anterior uveitis. So that is again a complication which can occur in patient with spondylo-arthritis. What is this? So again, a patient with who initially presented with lower back pain, and now presented with this skin rash. So what is it? What is it? Over the soles.
Hyperkeratosis.
Keratoderma blenorrhezica.
So this is keratoderma blenorrhezica, which can happen after reactive arthritis, right? Which can happen after reactive arthritis, right? Okay, this is classical picture of keratoderma blenorrhezica. So list 3 abnormal features.
Nail pits.
Nail pitting,
Oncolysis.
Onycholysis, and nail ridging as well. So what is the sort of the conclusion or a diagnosis? You can't say diagnosis. What is this?
Psoriatic.
Psoriatic arthritis.
Psoriatic nail changes, right? Psoriatic nail changes. Right. List 4 abnormalities.
dactylitis,
Can you repeat again?
dactylitis,
Right, dactylitis here. Right, it looks like a sort of a sausage shaped finger. Right, dactylitis. Then
Distal interphalangeal joint in
distal interphalangeal joint involvement in, here, right? And then psoriatic nail changes as well, right? So the patient has got dactylitis, distal interphalangeal joint involvement, and the psoriatic nail changes. So this is again a patient who presented with pain, arthralgia of small joints of the hands. So what may be the diagnosis? What are the
Psoriatic arthritis.
what are the radiological abnormalities?
Erosive lesions involving the interphalangeal joints, penicillin cuff lesions.
So again, don't say interphalangeal joint. So you have to be specific. So are they proximal interphalangeal joints or mainly distal interphalangeal joints?
Mainly distal interphalangeal.
Mainly distal interphalangeal joints. So in addition to that, they have a lot of erosions, and here it may be even these two areas there may be evidence of some penicillin cup appearance, right? So this is again what is the again here as well, right? So what is the most likely diagnosis in this patient? Involvement of the psoriatic arthritis, right? Distal interphalangeal joint involvement and penicillin cup appearance. Okay. Right. Again, this patient presented with polyarthralgia, especially bilateral knee joint pain.
Osteoarthritis.
Can you
Heberden nodes and Borchard's nodes are there.
Right, very good. So in over the distal interphalangeal joints, so what are the nodes?
Heberden nodes.
Huh? Heberden
Heberden.
nodes, right? In the distal interphalangeal joint, the patient has got Heberden node. And over the proximal interphalangeal joints, they're having somewhere here. So what do you call that? Borchard nodes, right? So when do you get this? In
severe case.
In
osteoarthritis, bony swelling.
In osteoarthritis, again, you will not get 10 out of 10.
Severe cases.
In severe cases, so this patient may be having this. So it's not in advanced severe case. So there is something called nodal osteoarthritis, right? Nodal osteoarthritis, right? So these are Heberden nodes and then Borchard nodes, and seen in patients with nodal osteoarthritis, right? So what is the most likely diagnosis?
Osteoarthritis.
Rheumatoid arthritis.
Right. So what are the features that would support the diagnosis of osteoarthritis?
It seems like rheumatoid arthritis. Is it thumb and ulnar deviation?
So when you look at the interphalangeal joints, so out of proximal and distal interphalangeal joints, so what are the joints mainly affected? Proximal interphalangeal joints or distal interphalangeal joints?
Proximal.
So these are distal interphalangeal joints. These are proximal interphalangeal joints, right? So when you look at the distal and proximal interphalangeal joints, so what are the joints? So what joints are mainly affected?
Distal interphalangeal
So it
joints.
is distal interphalangeal joints, right? So what has happened to the joint space?
Lost. Joint space has been lost.
Right. So there's narrowing and almost the joint spaces are basically already gone, right? So and mainly the distal interphalangeal joints are involved, right? So if the distal interphalangeal joints are involved, it would suggest osteoarthritis or rheumatoid arthritis.
Osteoarthritis.
So it's more likely to be osteoarthritis. So even in osteoarthritis, they can develop all these subluxations and all that as well, right? But if the distal interphalangeal joints are involved, we must always think about osteoarthritis and psoriatic arthritis, right? So this would favor osteoarthritis than rheumatoid arthritis due to the involvement of the distal interphalangeal joints. So what is this?
Gout.
Right, gout. And so what is this? The radiological appearance, what do you call that?
Bone cyst.
Juxta-articular erosion.
So this is almost a juxta-articular erosion. Can you be more specific about this erosion? In gouty arthritis, you get juxta-articular. So this is almost something someone has. It looks like someone has.
Osteopenia. Osteopenia.
Right, very good. This is some kind of a puncture lesion which is seen in the juxta-articular region. This is called gouty arthritis, right? So this osteopenia, now usually osteopenia is not classical in gouty arthritis or psoriatic arthritis, right? The osteopenia is seen in patients with rheumatoid arthritis. That is what is given in the book. So periarticular osteosclerosis can be seen in osteoarthritis. In rheumatoid arthritis, they can have osteopenia. No osteopenia is usually seen in gouty arthritis or psoriatic arthritis. Right. This patient presented with bilateral knee joint pain.
Pseudo gout.
Right. Very good. It looks like pseudo gout. So why do you say it is pseudo gout?
Chondrocalcinosis, that gap is also narrow.
So again, the patient has got chondrocalcinosis, right? Chondrocalcinosis. This is typical of pseudo gout, right? So any other metabolic condition where you can have where patients could develop chondrocalcinosis?
Hyperparathyroidism, hemochromatosis.
Hemochromatosis, primary hemochromatosis, right? Mainly
Yes.
primary hemochromatosis. They can develop.
Chondrocalcinosis, pseudo gout.
Right. Okay. Right. So back to the first question, right? So what are the similarities and differences between rheumatoid arthritis and spondyloarthritis? According to the presentation. joint involvement, investigation findings, and basically about management. So we discussed a lot, isn't it? Right? I think you have to, I'm not going to give the answer for this question. This is all sort of basically theory, and you must know the differences between rheumatoid arthritis and spondyloarthritis, right? So I'm not going to discuss this answer by myself, and you all have to give the answers, right? So what are the differences when it comes to presentation? Rheumatoid arthritis and spondyloarthritis, similarities and differences. ඔගොල්ලෝ කියන්න ඕන මම කියන්නේ නැහැ මේක.
Both having morning stiffness as they are inflammatory arthritis.
Okay, very good. Then
Considering age, rheumatoid arthritis is basically present at 30 to 50 years with
okay,
female
right,
predominance before menopause.
right, okay, good,
Spondyloarthritis, late teenage onset, basically males. And
right,
rheumatoid arthritis onset, and the both have the inflammatory features, and both have extra-articular manifestations. And in spondyloarthritis, back pain at person at night and improves when getting up. And in mostly rheumatoid arthritis, the joint systemic myalgia, fatigue, low-grade weight loss, and those things. According to the type of spondyloarthritis, there may be psoriasis and inflammatory bowel disease or urethritis in spondyloarthritis in presentation.
okay, right. Can someone mention about joint involvement?
In spondyloarthropathies, it's mainly an oligopolyarthritis with axial involvement, and in rheumatoid arthritis, it's a symmetrical polyarthritis with prominent involvement of MCP and PIP joint with the bearing of the DIP radical in pharyngeal joint. There are progressive features of both.
So what are the deformities you can get in rheumatoid arthritis?
Botonia deformity, swan neck deformity, and the ulnar deviation. In psoriasis, telescoping of joints,
anything?
arthritis mutalis.
Right. Anything else in the rheumatoid arthritis? Swan neck,
Set
Botonia,
thumb,
thumb, and
Palmar subluxation.
Okay, subluxations, ulnar deviation, right? All that. And suppose in ankylosing spondylitis, what are the deformities they can develop?
Kyphocoliosis.
Okay, basically a straight, very stiff spine, and what would happen to the neck? Fixed flexion of the cervical spine, isn't it? Right. So investigations and then basically we discussed, and you can read about management of rheumatoid arthritis, right? And then about the X-ray findings, I think we went through the X-ray findings, isn't it? Osteoarthritis, and in gouty arthritis, you must specifically know about juxtaarticular point out lesions. In pseudo gout, it is chondrocalcinosis. Psoriatic arthritis, they can have arthritis mutilans and advanced erosions and all that lead into penicillin cup appearance and involvement of the distal interphalangeal joints, right? In ankylosing spondylitis, as we discussed, it may be erosions or sclerosis of the sacroiliac joints, and then squaring of the lumbar vertebrae, right? And then there will be evidence of bamboo spine and all that, syndesmophytes and calcification of the interspinous processes and all that, right? And when you look at the neck, there may be severe flex deformity, the cervical spine X-rays, right? Osteoarthritis, again, it is the involvement of the distal interphalangeal joints, right? So rheumatoid arthritis will have juxtaarticular, periarticular, they will have periarticular erosions in rheumatoid arthritis. In addition to that, they will have periarticular osteopenia and osteoporosis as well in rheumatoid arthritis, apart from the all the deformities they can develop, right? So the main pathophysiologically main difference between rheumatoid arthritis and spondyloarthritis is in spondyloarthritis, the more prominent feature is enthesitis, right? Enthesitis. So that is enthesitis is not seen in patients with rheumatoid arthritis. Rheumatoid arthritis is mainly joint synovitis, right? Not enthesitis. Right. Any questions about the things here which we discussed today? So again, this you all have to again write down and keep about the radiological findings of each of these conditions, right? And again, you have to keep a record about differences between rheumatoid arthritis and spondyloarthritis differences, right? So those are the things. Now, if someone is coming with backache and lower backache and all that going on for 2 to 3 months and all that, if you start suspecting about rheumatoid arthritis, and if you do not look at the sacroiliac joint properly, so then you will miss the diagnosis of early ankylosing spondylitis, right? So you will keep on giving medication, just pain relief, and will do ESR and rheumatoid factor in those kind of patients. And finally, this patient would develop irreversible damage. So that should not happen. So people will definitely test that at the exam level. Right. Anything else? Any questions? Chat. Chat here. So newborn formation in ankylosing spondylitis, it is the syndesmophytes, right? Which I showed. So when will the clinical start? So you again you have to ask that question from our dean. I think probably at this stage there is no kind of community transmission. I think we should go back to the normal this thing, like in the government sector or the officers and all that. I think we should go back. I don't know why things are not happening. Probably if something happened to a university student or a scholar ළමයෙකුට වුණොත්, it will be a big hahu, and that may be the reason why people are delaying that, right? So then about this, dear sir, may I kindly request you to do the arrhythmia lecture you done for the 37th batch again. It was good. Did I do a arrhythmia lecture? So
But
did
it
I?
was. Not
Beg your
through
pardon?
Zoom. Not through Zoom. Sir
Right.
previously did.
Right. Did I do that for you all? Sorry, ma'am.
For 37th batch, sir did it.
Right. For you all who did that lecture. මම නෙවෙයි ඔයගොල්ලන්ට කරේ. මට ලැබෙනවා. So then done for the 37th batch. Again. But due to speed not get well and most of them did not participate. So did I do a නෑ ඒක මේ පුතා මේ මම මේ Zoom එකෙන් කරපු lecture එකක් නෙවෙයි. If you all want I can arrange that. So I think can the batch rep speak to me about this? So then I will discuss with this Dr. Herath and try to arrange that, right? Do rheumatoid arthritis patients get bronchoalveolar carcinoma as pulmonary manifestations? As far as I know, answer is no. So when you go through the Kumar and Clark, I think they haven't listed bronchoalveolar carcinoma as a pulmonary manifestation of rheumatoid arthritis. So they have all these nodules and all that, but they have not listed bronchoalveolar carcinoma as a respiratory manifestation of rheumatoid arthritis.
Excuse me.
Yeah.
Sir, in a history and examination suggestive of spondyloarthropathy, do we definitely have to do a HLA testing?
In your end, so normally we don't do that, but in your exam setup, I think you have to tell that, right? If you do not mention that, because when it comes to rheumatologists and all that, they do it. Even in private sector, they will do that, right? Because of that, I think we need to. So otherwise, people will think that you don't know about HLA typing and all that in spondyloarthritis. Right? In the exam setup, yes, you have to mention that.
Thank you, sir.
Right. So about all these ecological maintenance and all that, yes.
Sir, excuse me, I have a question about the management part, sir.
Right.
In sir, rheumatoid arthritis, we can change and modify management according to disease severity in scope we are calculating.
Right.
Inside spondyloarthritis, there any way we can objective assessment that thing?
I think it's about again the inflammatory markers, CSR and all that, and CRP. And if again the patient's the clinical features are, clinical symptoms are persisting despite the analgesics and physiotherapy and all that, right? And in addition, if the patient is developing mild kind of initial stages of things like SI joints erosions and all that, right? So definitely we have to start. There is no sort of clear-cut management guidelines as for rheumatoid arthritis when it comes to spondyloarthritis, right? And usually all these biological agents are being started by the rheumatologist and all that. My experience minimal about starting biological agents in spondyloarthritis, right? But the basic, the principle is before they go into that, before they develop the advanced disease, right? Yes, we have to prevent that by starting treatment, right? So the biological agents will do that together with the exercise and all that, right? And definitely there is a, because of that, definitely there is a place for biological agents in the early part of the disease to prevent them developing all the complications and all that.
Okay, sir. Thank you, sir.
Right. About the skin disorders and all that again, right? Okay, I will about arrhythmias, skin disorders and hematology, right? I will have a chat with Dr. Herat and I will let you know, right? Okay. I think when it comes to the exam and all that, I think you all have to know the basically the basic principles about management and all that, right? Now, when it comes to management of hepatic encephalopathy and all that, if someone writes about giving IV lactulose, right? What do you feel? So not a single person, but there are. Now I have gone through about 90 scripts, and a lot of people, about 4 or 5 people, have written giving lactulose intravenously. Don't do that, right? So you get really upset, and especially people like Malanga Singer will get extremely upset when you go through a script like that, right? Answer like that, right? Giving intravenous lactulose and all that. Suppose you can mistakenly say, rather than giving oral metronidazole, you can write IV metronidazole. That's all right. But if someone writes, I giving lactulose intravenously, so it doesn't look good. When you become house officers and all, if you write IV lactulose in the PhD, the nurses will start laughing at you. Right. Mama, then make a program. I will stop this session. Right. I have to go. I have to start making papers and all that. And I will have a chat about this arrhythmia lecture and then about hematology and dermatological conditions. Right. I will have a chat with Dr. Herat and then we will let you know. Harined, shall I stop now?
Thank you, sir.
Right. Okay. Right. Thank you very much.
Thank you, sir.
Thank you very much.
Thank you, sir.
Thank you.